Hi, everyone. Welcome to our conference. My name is Dr. Rebecca Gilbert, and I'm Chief Mission Officer at APDA. It is my pleasure to welcome you to this special keynote session entitled New PD Treatments on the Horizon with our expert speaker, Dr. Vivek Unni. Let me introduce you to Dr. Unni. He's an Associate Professor of Neurology at the Oregon Health and Science University, that's OHSU, School of Medicine in Portland, and he's the Director of the Jungers Center for Neurosciences Research at OHSU. He takes care of people with Parkinson's and related disorders and uses his training both on the patient care and research aspects of the disease. Dr. Unni is a member of APDA's Scientific Advisory Board and past recipient of APDA's esteemed COTSIUS Research Fellowship, so a true friend of APDA. We are so happy to have Dr. Unni here with us today, and he'll answer your questions live after his presentation, so to be sure to include your questions in the chat. Dr. Unni, take it away.
Thank you, Rebecca, for that kind introduction. As Rebecca just mentioned, I spend almost all of my professional life focused on Parkinson's disease and related diseases, both in my clinic and in my research lab. And although I give a lot of talks, most of them are to researchers. So it's a real honor and a pleasure to be able to speak directly to so many people with Parkinson's disease, their loved ones, their caregivers. When Leslie and Rebecca approached me about giving this keynote, I jumped at the chance because when they said they wanted someone to talk about what's coming down the road, it's a question that I get asked a lot in clinic when I'm seeing patients. It's probably maybe the most frequent question I get, to be honest. Probably at least once or twice a day when I'm in clinic, a patient will ask me, what's new, what's around the horizon. So I'm really looking forward to speaking to you all about this topic. So let's just jump right into it. Sorry, let me just get this started. Okay, so I've budgeted about 40 minutes for me to talk because I want to leave plenty of time at the end for your questions. And here's just a brief outline of what we're going to talk about. We're going to start with just some defining some terms. So we use these terms a lot: symptomatic versus disease-modifying treatment. Many of you may know what they mean, but some of you may not. So just to get all of us up to speed, because it comes up a lot when we talk about what are treatments for Parkinson's disease that we have now and what do we expect coming down the road. And then we'll spend just a little bit of time talking about the symptoms of Parkinson's disease, both the motor and non-motor symptoms, because we have different kinds of medications and people are working on both of those kinds of symptoms and new treatments for those symptoms as kind of separate classes of diseases. We'll talk about what disease modification really means and how that relates to new treatments. I'll give a brief review of what treatments do we have already, what the FDA has approved for Parkinson's disease in the United States. We'll talk a little bit about how clinical trials work, just to give you some background so you can understand some of the nomenclature when we throw out these terms like phase 1, phase 2, what does that really mean? And then I'll give a very brief overview of all the trials that are happening right now, just in pictorial form. There are over 100 trials right now that are going on for Parkinson's disease. And of course, there's no way we can really talk about them all in such a short period of time. But I just want to give you kind of a brief overview and some information about where you can learn more about these trials. And then we'll talk about some very specific ones. Disease-modifying trials, what that means, what is Parkinson's disease, what are some of the more exciting or interesting trials that are out there that have just reported or we expect will be coming down the road soon. And I'm going to focus most of the time that I'm talking about specific trials on the disease-modifying ones, because as we'll get to very quickly, we don't have any disease-modifying treatments yet for Parkinson's, although there's a lot of interest and effort in that. And then I'll just give some very brief highlights of some symptomatic trials that are currently ongoing. And then we'll take your questions, and I just put some of the key references that I've used and cite in this talk at the end for you guys to have for your own use later on if you're interested in learning more. Okay, so what do we mean when we say disease modification versus symptomatic therapy? And so one way to try and explain what these concepts mean is this graph, which I'm showing you right here. So on the x-axis, we have time. So in our case, we can just think of this as, let's say, years that a person has Parkinson's disease. And on the y-axis, we have motor performance. It doesn't really matter what specific motor task we're talking about in this case. There are many of them that we could use. We could use, let's say, walking speed or ability to do finger tapping or hand coordination, any of the things that can be affected in Parkinson's disease. And but it has to be something we can measure and we can quantify. And so for all of us as we get older, it's not uncommon that on any specific motor task, we become slower at it or less able to do it with time. So that very top straight line that I have there that's going down at a very gentle angle, that's normal aging in the dark blue. Now, when someone has Parkinson's disease and it's not treated, in the black line, you can see that their motor performance gets worse over time, worse than if they just were getting older normally. And then if we start a treatment, so at that dashed line, let's say it's a symptomatic treatment, levodopa in the case of Parkinson's disease is the classic example of a symptomatic treatment. What happens? Okay, we start the symptomatic treatment, well, let's say it's levodopa in this case at that dashed line, and they get better. Whatever motor performance number we're following over time, we see an improvement. But with the symptomatic therapy, what it means is it's treating the symptoms, but it's not affecting the overall disease course. So what happens? Over time, that motor performance gets worse, very similar to the way it would if they weren't being treated in terms of the course over time. Now, a disease-modifying therapy is different. It doesn't necessarily improve any symptom at all. Actually, most of the time, a purely disease-modifying therapy won't improve any particular symptom. But what it does is it stops the disease or slows the disease down. So in the ideal case, a disease-modifying therapy that could stop the progression of Parkinson's disease completely would halt the disease at that particular time when you started the treatment. So in the light blue, that straight line is an example of what might happen in this theoretical case, this hypothetical case of a disease-modifying therapy. It wouldn't improve the person's symptom at that time, but now the course that they would follow after they started that treatment would be much more like the normal aging course. Whatever motor task we're following would slowly get worse with time, as it would if the person were just aging normally, but it would not get rapidly worse over time as it does with untreated Parkinson's disease or symptomatic therapy. So that's kind of the key distinction between the two kinds of therapies. And as many of you know, and which I will review in just a few slides, we have a lot of symptomatic therapies that have been approved by the FDA for Parkinson's disease, but we do not have a single disease-modifying therapy yet in Parkinson's disease. And there's a lot of work and effort going on in that space, which is why I'm going to spend a little bit more time in this talk talking about the possible disease-modifying therapies that are coming down the road. Okay, so when we talk about symptoms first, what do we mean? So for many of you in the audience who have Parkinson's disease or care for someone with Parkinson's disease, you'll know this, but I would say most people who aren't as familiar with Parkinson's disease don't realize that there's a lot more than motor symptoms to Parkinson's. So Parkinson's is defined by its motor symptoms. You have to have these motor symptoms in order to have Parkinson's disease. And the classic ones are slowness of movement, which the medical terminology for that is bradykinesia. You may hear that term. Tremor, joint stiffness, especially kind of stiffness to passive movement of the joint, which the medical term for that is rigidity, and then gait and balance difficulties. And almost all of these motor symptoms are due to loss of neurons in the brain that make a neurotransmitter called dopamine in a particular part of the brain called the midbrain. Well, as I mentioned, the disease is defined in many ways by the motor symptoms, and when you just say Parkinson's disease to the random person on the street, they probably think of the motor symptoms. But what has become much more appreciated over the last 10 or 20 years is that there's a lot more than motor symptoms in Parkinson's disease. There are a lot of non-motor symptoms. And in many patients, it's the non-motor symptoms actually that cause the most disability or decrease in their quality of life. And almost all of these non-motor symptoms are not related to the loss of dopamine neurons in the brain. And so the standard treatments that we use to treat the motor symptoms of Parkinson's disease usually do not help these non-motor symptoms, and sometimes can make them worse, actually. So here's just a list of some of the most common non-motor symptoms. So cognitive trouble or dementia can happen in people with Parkinson's, hallucinations, blood pressure regulation problems. So especially a drop in blood pressure when people stand up that can cause them to get dizzy or faint. REM sleep behavior disorder, which is an acting out of dreams at night. Urinary symptoms like urgency, frequency, incontinence. So a sudden urge to urinate or having to urinate very frequently are very common in people with Parkinson's. Constipation, difficulty swallowing, loss of sense of smell. These are all some of the non-motor symptoms that we see in Parkinson's disease. So what do we have already? So I took this, the next set of slides from directly from the APDA website, and the link is at the bottom of the slide. So if you're interested in looking at this in more detail, I urge you to take a look at the APDA website. I'm not going to go through all of these in great detail because there are a lot of them, and I'm showing them more to give you a sense of what's out there. So these are treatments that have been approved by the FDA as of November 2024 for the treatment of Parkinson's disease. And you'll see we have a fair number of treatments for the motor symptoms. I'm just going to talk about them in classes. So you'll see there's a lot of different treatments that are different ways of administering levodopa to people. So either in pill form, disintegrating tablet form, subcutaneous infusion was just approved, a powder that you inhale was approved a few years ago. So these are all forms of levodopa that can be given in different ways to a person to treat the primary motor symptoms of Parkinson's. There are also treatments that have been approved that slow the body's breakdown of dopamine. I should say, for those of you who don't know, just going back a slide, so levodopa is a precursor to dopamine. So when you give that to a person with Parkinson's disease, the body turns it into dopamine to help replace the dopamine that was lost by those neurons that are dying in the midbrain. And so that's probably still today the gold standard treatment for the motor symptoms of Parkinson's disease is this dopamine replacement therapy with levodopa. But we have other strategies. So there's a group of drugs that have been approved by the FDA that slow the breakdown of dopamine by the brain. So that increases the levels of dopamine in the brain. Entacapone is probably the most widely used. Opicapone is one that I'll talk about briefly later on in the talk. We have a range, a half dozen or so of dopamine agonists. So dopamine works in the brain by binding to a specific set of receptors on cells that activate or inhibit those cells. And we have specific drugs that bind to those receptors as well and can help replace the action of the lost dopamine. So there's about a half dozen FDA-approved medications already to treat the motor symptoms, once again, that are we call dopamine agonists. We have another class of drugs that also slows the breakdown of dopamine by the body, so that increases the levels of dopamine in the brain. Those are called MAOB inhibitors, and we have another almost half dozen of those that are out there. And then we have a group of drugs that don't act directly on the dopamine receptor, but act via different mechanisms to try and treat, once again, the motor symptoms of the disease. Now, we have all those drugs that I just reviewed very quickly that treat the motor symptoms. We also have 3 FDA-approved medications that treat some of the non-motor symptoms. So we have pimavanserin or Nuplazid, which treats psychosis, so hallucinations and delusions in Parkinson's disease. We have droxidopa or Northera, which treats orthostatic hypotension. That's that drop in blood pressure I was mentioning before when people stand up that can cause them to fall. And then we have rivastigmine, which is used in Parkinson's disease to treat cognitive dysfunction. So we have all those treatments for the motor symptoms, and very few treatments that are specific for Parkinson's disease for the non-motor symptoms. And as I said before, we have no treatments yet for that are disease modifying, that actually affect the course of the disease itself. So what's coming down the road? So before we get to the actual trials that are currently going on, I'm going to give you a brief review, a very brief review of how clinical trials work in the United States. And I wanted to do that to give you some perspective of what we mean when we use these terms like phase 1, phase 2, phase 3 clinical trials. And probably one way to think about it is in this picture, I've shown one of my favorite paintings by a Renaissance artist. It just shows a road going off into the distance. And way off in the distance, if you can see those houses way down the road, far off, that's what I would think of as sort of a phase 1 trial. So a phase 1 trial, and I'll give you more information on the next few slides, is a very early trial. And so something that's positive in a phase 1 trial may end up helping people with Parkinson's disease, but we're talking about something that's more far off in the distance in terms of how immediate of an impact it might be. While a phase 2 trial might be something more in the middle, maybe that bend in the road that we can see where it goes off to the right. It's sort of an intermediate kind of trial in terms of how quickly it might impact a person with Parkinson's disease today. While a phase 3 trial is a much bigger trial, and a positive phase 3 trial, especially if there are several of them, can directly affect what the FDA approves and what prescribers prescribe, physicians might prescribe for patients who have Parkinson's disease. So a phase 3 trial is something that's much closer to us right now, in the foreground of this painting, let's say. Okay, so how do clinical trials work in the United States? So I took this straight from the NIH website. In general, things are divided into 3 phases in terms of clinical trials, and they're usually done sequentially, and each one has a different purpose. And one thing I want to get across is that phase 1 and phase 2 trials often, although we look for efficacy, so we look for evidence that maybe it might be helping people with the disease we're interested in, they're not really set up per se to tell us whether they help people. They're more set up to look at safety and side effects. So in general, a phase 1 trial in the United States is set up to test in a small group of people, usually healthy volunteers. And when I say small group, let's say on average, there's a lot of play here, but between 20 and 80 people might be in a phase 1 trial. And they're usually healthy volunteers, and we will give them the drug or the treatment and follow them. And what we really want to know is how safe is this drug in these people, and are there any side effects that they're getting from it? And if that looks good, in that there's no safety issues or side effect issues that prevent us from moving forward, the next step is a phase 2 trial. So a phase 2 trial is bigger, and now usually involves patients with the disease you're interested in. So in our case, Parkinson's disease. So maybe on the order of 100 to 300 patients. And once again, although we will often look in a phase 2 trial to see whether it's helping them with their symptoms, that's not the major purpose. A phase 2 trial also is looking at whether this drug is safe in this particular patient population. Because you can imagine a drug might be safe in healthy volunteers who are college students, but when we give it to people with Parkinson's disease, who have a different, who are often in a different stage and age, the drug might work very differently in them and could have side effects or toxicities that don't appear, let's say, in younger people. So we look at a combination of efficacy and is it safe? And if it looks promising in a phase 2 trial, then we move on to the much larger phase 3 trial. And so this is where the drug is given to a larger group of patients. On average, roughly between 1,000 and 3,000. But, these numbers, I put them up here because they're just a guidepost. A lot of it depends on the disease. If it's a disease that has let's say, very few patients, then the phase 3 trial may be a much smaller group. While if it's a disease that has a much larger group of patients, let's say diabetes or heart disease, then a phase 3 trial could be much bigger than 3,000 patients, and often is. And here we're looking at a lot of things, but this is the first study that's really powered in a statistical way to try and test what is this medication effective, in our case, let's say for Parkinson's patients. And also, of course, it's going to look for side effects. You can imagine when you start giving the drug to a much bigger group of people, more rare side effects might be noticed than you would have seen in the smaller group in a phase 2 study. So you're going to look at effectiveness, side effects. We're going to sometimes we compare it to other treatments that are already approved, and all that information will be collected. And if it's positive, a phase 3 trial is the kind of trial that can be game changing, because that's the kind of trial that will change how we treat people with, let's say, Parkinson's disease. Now, a phase 4 trial, I'm putting this up there so you know that term. It's actually a trial of a drug that's already approved by the APDA, but it's to track it over time. Because even, let's say, a phase 3 trial, if we study it in 3,000 patients with Parkinson's disease, when we roll it out to the world, there are probably 20 million people in the world with Parkinson's disease. So you can imagine there may be, and there's documented cases of this in other diseases, where, let's say, side effects or toxicities that we didn't know about from the phase 3 trials come to the fore once it's actually been used by in clinical practice around the world. And if there are toxicities that come up in that case, the only way to know about it or let's not the only way, but a good way are these phase 4 trials. And then if it looks like there are issues with it, the FDA may actually remove approval for a drug. So that's kind of a very brief overview of how the clinical trial system works in the United States. So I don't want you to squint at this slide. I'm not putting this up here for you to look at in detail. I'm going to show it to you in the next few slides in a bigger way, so it's easier for you to read, but I just wanted to show it here once, just to give you a sense of all the clinical trials for Parkinson's disease that are going on in the United States right now. And I took this from a very nice review that's published in the Journal of Parkinson's Disease, and I have the full reference at the very end of the talk by McFarthing and colleagues, and it's a review I think they've published annually for the last 5 years, this group. And it's interesting because most of the authors of this review are actually Parkinson's advocates. They're not scientists or researchers or physicians. And I think they do a very nice job of summarizing all the clinical trials going on around the world in Parkinson's disease, and also giving people a sense of the year-to-year changes, what's happening with those trials over time. And so I took this figure from the most recent one that was published, I think, in November or December last year. And it presents the data of all the trials in this kind of pie chart. And you can see a little less than half the trials that are currently going on are these disease-modifying trials, which I mentioned earlier, we talked about just at the beginning. And a little over half are symptomatic therapies. And then they break it down further into pie wedges, where you have phase 1 trials, phase 2 trials here, and then phase 3 trials. And they talk about the mechanism of action of those drugs in these colors right here. And like I said, I don't want you to try and read this slide per se. We're going to look at it in more detail in the next few slides. So we're going to talk first about the disease-modifying trials. So here, I'm showing you just the top half of that graph, where we have all the disease-modifying therapies that are currently being tested in clinical trials for Parkinson's. And you can see we have about 20 phase 1 trials going on right now. We have a bigger group of phase 2 trials, maybe almost double that. And then currently we have about 3 phase 3 trials that are disease modifying around the world, I should say, for Parkinson's disease. And I'm going to talk about, before I get to the specifics, and then for the symptomatic trials, we have kind of a very similar pattern. We have a certain number, roughly 20 phase 1 trials looking at trying to treat the symptoms of Parkinson's. We have once again about twice as many phase 2 trials, those intermediate trials. And then we have more phase 3 trials in this case, about 7 or 8 phase 3 trials that are currently undergoing. And I'm going to talk about a few of these in more detail towards the end. Okay, but let's start with the disease-modifying trials. And so once again, just to review, a disease-modifying trial does not necessarily treat a symptom. It does not necessarily make a patient's symptom better. The goal of a disease-modifying trial is to slow or stop the disease from getting worse. And so, as I mentioned before, we don't have yet a disease-modifying therapy in Parkinson's disease. Okay, so of the 3 disease-modifying trials that are phase 3 right now, the one I'm going to spend a little bit of time talking about, or the class of drugs also that I'm going to talk about, relates to this exenatide trial. So in that pie wedge, or that pizza wedge, you can see under phase 3, it's in that light blue, because what it's focused on is a kind of target, which is called a GLP-1 receptor agonist. I'm going to talk about that first. Then I'm going to talk a little bit about antibody trials, which are directed in Parkinson's disease against alpha-synuclein, which you can see in that green color in the phase 2 areas. And then I'm going to talk at the end of this section about LRRK2 kinase inhibitors, which you can see under the phase 2 section in that yellow region. Don't worry too much about the names or the colors here. We'll talk about what's important when we get to it. Okay, so we're going to start with the GLP-1 receptor agonist. You may have heard of these drugs. They've become very famous in the last few years. GLP-1 is a particular receptor. It's a protein that's found on cells that binds a hormone that's called glucagon-like peptide that's involved in regulating blood sugar and other processes in the body. And an agonist just means activator. So it's a molecule that binds a receptor and activates it. And there are several medications that are approved in the United States that are GLP-1 receptor agonists that treat type 2 diabetes. Some of them are very famous, like semaglutide, which is Ozempic, or exenatide, which is Byetta or Bydureon, or liraglutide, which is Victoza, lixisenatide, which is Atlixin. So these medications, or this class of medications, has kind of taken the world really by storm because they have been so effective in treating certain diseases, specifically diabetes and obesity. And it seems like they may be effective in other diseases too. There's data out there that people who were given these drugs who were affected by COVID had decreased mortality. So there's a lot of hints out there that maybe these drugs could potentially be useful in other diseases. So there's been an interest for a while now in studying them in Parkinson's disease. On the bottom right is just kind of a stick figure which shows this molecule. It's a small polypeptide for those of you who are interested in the specifics. And it comes actually from the Gila monster. So that's the lizard you can see there on the bottom left, which is a mildly poisonous lizard that's native to the southwestern United States. And in screening for new molecules that might have an effect or be useful as therapies, scientists often look at venoms and toxins that are found in nature, either in animals or plants, because a lot of effective therapies over the years have come from those sources. And so from this Gila monster is where the first molecule of this class, which is similar to this exenatide example that I'm showing on the bottom right, came from. So there was a lot of excitement, and I would say there still is a lot of excitement about these GLP-1 receptor agonists in Parkinson's disease. And that's because there have been many, or let's say multiple, at least, phase 2 trials, so these intermediate trials that showed not just that it was safe and the side effect profile was good, but that there was improvement in Parkinson's disease and maybe some disease modifying effect of these drugs. And so this is just an example of 4 of these phase 2 trials looking at 3 of these different GLP-1 receptor agonists that all showed improvement in Parkinson's disease patients compared to a placebo. So that generated a lot of excitement and has generated a lot of excitement in the field. I'll just show you one example, which was published earlier last year. And this is of a particular GLP-1 receptor agonist. Once again, a phase 2 trial that was published in the New England Journal, a very reputable journal in our field, of course. And so this was for patients with early Parkinson's disease, less than 3 years of disease. And they were given this lixisenatide medication or placebo. They were blinded. The people running the trial were blinded, so no one knew who got what medication until the end. And these are often given as injections subcutaneously, so under the skin. And so they were given once a day for a year. And what they noticed in sort of the bottom middle part of this slide is that in the patients who did not get the medication, who got placebo, they got worse over time, as you would expect, which is what that bar off to the right is showing, which is worsening. While the patients who got the drug, lixisenatide, there was no change in this motor scale that they were measuring. So they did not worsen. So this was evidence, and this is evidence potentially of a disease-modifying effect, that it didn't improve the symptoms of the patients over time, but it stopped them from getting worse. And the side effect profile looked pretty good. As with many of these GLP-1 receptor agonists, the primary side effects that people get are gastrointestinal, so nausea, vomiting, reflux, and you see more of that in patients treated with these drugs, as would be expected. So this also generated a lot of excitement. But to give you the latest update, so this was just came out a few weeks ago. So there was a phase 3 trial that just finished, and unfortunately the results of this trial were negative. So this was done in the UK. It was a phase 3 trial, many centers, and the particular GLP-1 receptor agonist was this exenatide, Ozempic medication. And what they showed was that it was safe and it was well tolerated, but they did not see any evidence that it actually improved people's Parkinson's disease. So their interpretation of this was that there was no evidence of a disease-modifying effect, but maybe it's still worth studying, because if you look at specific subgroups of people with Parkinson's disease, maybe it might be more effective in that subgroup. Or if you had a better way of testing target engagement. So what that really means, if you had a better way of telling whether the drug is actually acting the way you want it to work in the brain, then maybe it would show promise. So I must say that was a bit disappointing when it came out. But there are that was a phase 3 trial, like I said, one of the big trials, which if it were positive might have changed how we treat Parkinson's disease. But there are 3 phase 2 trials and 1 phase 1 trial that are still going on, looking at this class of medications. Those are in the light blue in the middle of the phase 2 pie slice. Semaglutide, exenatide, and this NLY-01 compound are being currently tested. And so we don't know the results of those phase 2 trials, but if they're promising, they might move forward to a phase 3 trial. Okay, so that's one kind of general class of medications that's received a lot of buzz, these GLP-1 receptor agonists. The next class of disease-modifying drug that's received a lot of buzz are these antibody trials. And so we're going to talk about them next. Now, antibody trials are, they're 2 different kinds. And but maybe before I get to that, let's just talk a little bit about what do antibodies try to treat Parkinson's disease? So many of you will know that in Parkinson's disease, we have these aggregates, these clumping of a protein called alpha-synuclein into a structure called a Lewy body. And so I'm just showing an example of a Lewy body here. So on the left-hand side of this slide is a picture of an individual cell, a dopamine neuron in the part of the brain where dopamine neurons live, the substantia nigra, and it's filled with this brown pigment. Those are those brown little tiny little dots that you can see, and those are filling up the cell. And that's a normal thing. When a neuron makes dopamine as a byproduct, it makes this brown pigment called neuromelanin. But what's abnormal in that cell is that orange circle in the middle with the little black arrowhead pointing to it. That is a Lewy body. So that's full of aggregated alpha-synuclein. And we know to have Parkinson's disease, we define it this way, that people have to have these Lewy bodies full of aggregated alpha-synuclein in their brain, in neurons, which are destined to degenerate, die. And one of the more dominant hypotheses in the field right now about what is Parkinson's disease and how it spreads through the brain is this idea that was developed by a German neuropathologist, Heiko Brack and colleagues, which is referred to as the Brack hypothesis. But what it says is that Parkinson's disease actually begins in the body much earlier than we had realized before, and much earlier than when the patient develops symptoms that lead to the diagnosis. And exactly how this works is still, I would say, very up in the air. And I would say this is still a hypothesis. It's not definitively shown that this is what's happening, but I would say it is the dominant hypothesis. It's the one that most people believe and most people are testing. And what Brack said was that these Lewy bodies full of aggregated alpha-synuclein can begin in different parts of the body, either in the GI system, let's say in the stomach or small intestine, or in the nose, and then they spread through the nervous system into the brain. And at the phase 1 stage or phase 2 stage, they don't cause a lot of symptoms and no motor symptoms. They may cause some non-motor symptoms like loss of sense of smell and constipation, but not symptoms that lead someone to the diagnosis of Parkinson's. But then over the time, and we're talking about over the course of years, these Lewy bodies will spread through the brain. And eventually they'll reach those dopamine neurons in the midbrain when you get to stage 3 or 4. And that's when people develop the motor symptoms of Parkinson's disease and get diagnosed and usually get started on treatment. And then over time, these Lewy bodies spread even further to other parts of the brain. And that can cause some of the more advanced symptoms that we see in Parkinson's disease, including dementia and cognitive trouble. Okay, so there are multiple phase 1 and phase 2 studies using the immune system to try and treat Parkinson's disease. And so some of them involve activating the immune system to generate its own antibodies. Those are vaccines to target these alpha-synuclein aggregates in Lewy bodies and make them go away. And then there are other therapies that are passive. So in that case, instead of activating the immune system in a person with Parkinson's, you actually give the person an antibody against alpha-synuclein directly to try and treat the disease and stop these Lewy bodies from spreading through the brain and making a person's symptoms worse. And so there are many phase 1 studies right now going on of this active immunization, this vaccination basically. And there's a fair number of phase 1 and a few phase 2 studies of this passive immunization where you give the antibody directly to patients. Okay, and I'm gonna, in the interest of time, go through the next two pretty quickly. So there was a phase 2 study, so this intermediate study that was reported just a few months ago of one of these drugs, one of these passive drugs, that give the antibody against the Lewy body directly to patients, and it missed its endpoint. So it didn't show effectiveness, but there was some hint there that that it might be effective. So it's unclear. Roche is the company that's running this trial, what they're going to do next. But there's a decision to be made whether to go forward with a phase 3 study or not. Earlier, there had been another couple phase 2 studies which didn't meet their endpoints. This Roche one also showed a hint of effectiveness. So that's why they went forward with this second phase 2. And once again, they got this hint of effectiveness, but it didn't officially show effectiveness. So what's going to happen next and whether there's going to be a phase 3 study, I think is still up in the air. Okay, and then the last set of disease-modifying trials are these LRRK2 kinase inhibitors, which maybe you've heard about. And so just a brief update about them. Last year, we had a phase 3 study of these LRRK2 kinase inhibitors, but because it was taking so long to run the phase 3 trial, they were predicting it was going to take about 10 years. It was running much slower than they expected. Biogen, who's running this trial, decided to fold that phase 3 study into one of their phase 2 studies. And so now we have a phase 2 study, this BIB compound in yellow in the phase 2 pie wedge. But we don't know yet whether what that shows. And presumably, if it's effective, they will reinstate a phase 3 study of this compound. Okay, I know we're basically out of time. So what I'm going to do is I'm going to just skip ahead. And so there were 3 symptomatic therapies that I wanted to talk about. I'm just going to mention them here very briefly. Opicapone, which is one of those drugs that blocks the body's breakdown of dopamine. That is already FDA approved for people who have wearing off of their symptoms. But there's a phase 3 study right now to see whether it might be effective as an addition to levodopa in people who don't have wearing off. There's pimavanserin and rivastigmine, which are 2 drugs that are already FDA approved for people with Parkinson's disease with cognitive symptoms. And rivastigmine is now being tested in people to see whether it might prevent falls. And then there's pimavanserin, which is already approved for psychosis in Parkinson's. And there's an FDA, there's a phase 3 study currently going on to see whether it might help, what specific dose might be the best for people with Parkinson's. Okay, so I know I'm already a few minutes over time. So what I'm going to do is let's just get to the questions, because I think that's the most important part of all this all.
Great, thank you so much. That was amazing information. We have a lot of questions from our audience, and they're all really thoughtful and good. So let's try to get to as many of them.
Yeah,
so we have a great question from Patrick, which is, what outcome measure is used to determine whether a treatment is disease modifying or symptomatic?
Yes, that's a great question, Patrick. So there's no one standard approach, but in general, what people who run trials will do is they'll pick one or a few different outcome measures. So one very common one, let's say to look at motor symptoms, is the UPDRS motor scale. And so that's something that so we can do in the office. So when a person with Parkinson's disease comes into the office, we do a set of examination on them, and we can use this UPDRS rating scale to see kind of where their motor symptoms of Parkinson's disease are at any one point in time. And then we will follow that over time in people with in a clinical trial. And then we'll see, in general, that gets worse with time over the course of years in people with Parkinson's. And so if that doesn't get worse, that would be the kind of metric that you might use to look at, let's say, the motor symptoms. But there are other ones too. So there are quality of life scales that we use. There are other kinds of scales that you can use. So there's a kind of a variety of different ones, but they all have to be quantifiable in some way. So and they have to be validated in the sense that we have to know that they work well in people with Parkinson's disease and that they show worsening over time, so that we can test whether we're, let's say, slowing or stopping that worsening.
Fantastic, thank you. This is a great question from Kelly, which are, how are data numbers clean if patients in the trial are taking other medications, have different Parkinson's levels, are different ages? What does a trial do to account for that?
Yeah, that's another great question, Kelly, an important one. And it depends on the trial, exactly how they do it. So that's part of the reason the trials get bigger and bigger. in the sequence from phase 2 to phase 3 in people with Parkinson's. Um, One way of addressing that is to have a lot of people. So then if you have a lot of people in the trial, it's those kind of effects in any one person tend to wash out. Now, if there's something that's very specific to what you're interested in studying, then there may be restrictions on the trial. So it's not uncommon in disease-modifying trials where they want to look at people in the early stages of the disease to see if there's an effect, that they will not allow people to enter the trial, let's say, who are on symptomatic therapy for Parkinson's disease. So if they're on levodopa or they're on a dopamine agonist, they can't be in the trial because they don't want that kind of confounding effect, which you're bringing up. And in terms of vitamins and other medications, that's a more difficult one, to be honest, because we know that giving someone levodopa is going to improve their symptoms. So if we're looking at measures of their motor performance over time, maybe we know that we have to worry about that as a confound. Now, there are a lot of things that people do and that people take that we don't really understand how they work. So in those, we don't necessarily exclude them unless we have knowledge that they might affect it. But that's where doing these trials in a big group of people is important, so that the data is not kind of skewed inappropriately in one way because a lot of people happen to be taking some supplement that might actually be affecting the results of the trial or how we interpret it.
Great. Now let's take this question from Gerald. What is the normal or average time period to complete a full set of phases?
Yeah, that's a great question.
Beginning to end.
It varies a bit, but we're talking on the order of 15 to 20 years to go through the whole sequence, because the trial itself may run from 1 to 3 years each one, but there's a lead time, and then there's analysis time, and then there's in between the trials there's some time, because just because a phase 2 trial is positive doesn't mean it's going to go straight to a phase 3 trial. There's some decision making that needs to happen, and there's some lead up time, and that can take a year or two, even if the phase 2 is positive, and even if the company wants to move forward, there can be a year or two between when they start the phase 3 trial. And so we are talking on that kind of time scale from the very beginning to when a drug might be approved by the FDA and then roll out to people.
Great, thank you. And I think we'll take our final question now, and this is a question from Lowell. What about research being done on people with advanced Parkinson's? Anything specific there?
Yeah, no, that's a great question. There are some of those, I'm sorry I didn't have more time to get to it, but some of those symptomatic therapy treatments are kind of directed at people with more advanced symptoms. So I didn't mention it, but one of those phase 3 trials is looking specifically at people who have dysphagia. So that just means difficulty swallowing, so coughing or choking when they try and eat or drink, which can be a symptom that's more common in people with advanced disease. And there's a trial of a medication that's being conducted right now, a phase 3 trial, to look at whether this particular medication can help people with that kind of issue. And so there are a few of the phase 3 trials and many of the phase 2 trials that are looking at more advanced symptoms that you see in advanced PD.
Fantastic. That was an incredible amount of great information. I really wanted to thank you, Dr. Unni. Always there for us and always do wonderful things for APDA. So thanks again for this. That is all the questions we have time for today. Now, if you did post a question in the chat and we did not get to it, please copy that question now and post it in the remaining questions from sessions message board. And that's in the community section of the Whova platform. And we'll do our best to answer all questions posted there. So please do that so we have your questions saved. Again, want to thank Dr. Unni. Thank all of you for joining us. And for those who are interested in learning more about PD treatments, I recommend checking out our blog, a closer look blog on our APDA's website. And I talk frequently about various treatments and the future of PD treatments. We're going to take a quick break. Don't go far. We'll be back in approximately 8 minutes to begin our breakout sessions. We have lots of great options available. Take a look now at the agenda, decide which session you want to join next, and we will see you soon. Have a great break. See you soon.